Let's spend our remaining about 50 or 55 minutes this morning with neuro. And so here's what we're going to talk about in the next hour or so. We're going to look at headaches. And you know, in primary care, one of the most common patients or neurologic patients who comes in is someone that has a headache. And you really need to be able to know who's got a bad one. When do you have to get one of those expensive imaging studies? So we'll talk about that. And I want you to be a master of headaches in a primary care setting. You got to know about vertigo. Vertigo typically is a question that appears on the exam, one or two of them. It's very common in clinical practice, and you need to know how to differentiate central from peripheral vertigo. Very, very big deal. You need to know about neuropathy, whether it's a mononeuropathy, a polyneuropathy. Polyneuropathy is extremely common in people who have what very common disease? Diabetes, exactly. So we have to talk just a little bit about that. There's often a question on the exam about Parkinson's disease, and I want to make sure you have a heads up about that one. We'll talk about tremors in general. You know, there's a very common, and I want to make sure you know what you need to know. Multiple sclerosis is a very common immune-mediated neurologic disorder, and you got to have a heads up about it. You really do. And so I want to make sure you get it, especially if you see a question like that on the exam. And then finally, we will end with dementia, and then we'll let everybody go to lunch. All right? So let's get going. And the first thing we're going to talk about are headaches. And I know that everybody in this room has had a headache. Hopefully you don't have one right now. All right. So you know what that is. I'll bet that if you have a headache right now, or the last headache you had, I am hopeful that it was a primary headache, meaning it wasn't secondary to something else going on. What else? Oh, a bleed, increased intracranial pressure, a tumor, something else going on. When those produce headaches, we call them secondary headaches. Unfortunately, when an older patient has a presentation of a new onset headache, it is almost always secondary, which makes us worry a lot. Look at this question. Which patient has the most serious secondary headache? Well, these are never good headaches, but the one I'm worried about the most is not the 16-year-old type 1 diabetic with a headache. Number 2, the 21-year-old female using an intrauterine contraceptive. No. I don't like that one, but I'm going to see what else. 30-year-old who walked into the door frame in the middle of the night. They probably have a headache. The one I'm the most worried about, and the term you need to know, is a thunderclap headache. What's a thunderclap headache? A thunderclap headache is one of severe onset that happens right away. So it's an acute, severe onset. That is never good. You need to get those patients out of your office if they stumble in, all right? So get them out. The term you need to remember, thunderclap headache, circle number 4. A common cause of a secondary headache in older adults could be a brain tumor. What are the 2 most common presenting symptoms of brain tumor in adults? Well, to be honest with you, it depends on where the tumor is located, but what I want you to be alert to is seizure and or headache in an adult. That is never a good finding, circle number 3. So let's talk about how to approach a patient who comes in to see you and has headache. Well, in primary care, we're going to do it very differently than you might have done it if you worked in the ER, if you work in ICU, or you work in any other setting. Because in primary care, we see the masses. We see the general population who walk around with common things. If you work in ICU or your area of expertise is peds neurology, you'll say, oh, neuroblastoma is very common. Well, no, it's not. It's common in your area. But so I want you to have that perspective. So as you go in to consider and you take this exam, I want you to appreciate that the exam you're going to take is a primary care exam. So you're not going to see those special little problems that you see when you're in some specialty area like peds neuro. So how do you approach a patient who comes into your clinic with a chief complaint of headache? Well, you're going to do what you do with every patient. You're going to get a good history from them. But you know as well as I do that the majority of patients who come in with a chief complaint of headache into primary care have a normal history. Some red flags for history may be any of these. And I introduced a term to you, thunderclap headache. It often is associated with an arterial bleed, something like a subarachnoid hemorrhage. That's never a good headache, a thunderclap headache. If you work the ER, you know all about somebody who comes in and says, "This is the worst headache I've ever had." Like, that's never a good finding. So all of these are considered red flags with regard to history in a headache patient. The next thing you do after you get a history from your patient is you do a good exam on them. Generally with a headache, we do a focused exam, but here's what you need to remember. Headaches don't always start in the head. They can be referred in from somewhere else, and the most common somewhere else is the neck. And you know, if somebody's got cervical disc disease and that's why they're having this bad headache, you're going to feel mighty embarrassed if you get an MRI of the brain when you should have gotten an MRI of the cervical spine. You're going to feel mighty embarrassed if you work in the ER and somebody comes in with a really bad headache, feels like the top of my head is going to blow off, and you get a CT scan of the brain and they really have shingles on their scalp. So my point is this. When a patient comes in with a headache, we do a focused neuro exam, but if you don't find what you think you might find, you've got to stretch your differential, which means then you need to go with a good head-to-toe exam in this headache patient to figure out why in the world is their head hurting. So don't forget to check other things. Don't forget to stretch and build your differential. What about some red flags on exam? Well, listen, I hate to be the bearer of bad news. You know, when we talked about pneumonia, I threw out an age to you as an older pneumonia patient. What was that age? 65 years old. In the realm of neuro, with a new onset headache, you know how old is? 35. Did I just gut punch somebody? Because you're considered an older adult if you present with a new onset headache at age 35. I'm pretty sure if you present to an ER as a 35-year-old with a new onset headache bad enough to go to an ER, you just bought an expensive test, because 35 is older. So it's always in the context of the complaint that the patient has. So what do we look for as red flags on exam? Well, any neurodeficit, whether it's accompanied by neck stiffness that's going to be a red flag. But so is papilledema. And I think you're going to see that one on the exam. An example of papilledema, obviously, is swelling of the optic disc. It almost always is secondary to increased intracranial pressure. It typically is bilateral. And look at this instrument right here. I am pretty sure that you didn't see what you said you saw when you used that thing right there. And I know you didn't, because I didn't either. But you know what? I had to get out of that darn assessment class. So, here you are and you check off, you pick up your ophthalmoscope and you're like, red reflex elicited, and you were probably telling the truth. But then you were going in. And man, you started talking about all kinds of things like cup to disc ratios, and you didn't see all that stuff. But you had to get out of that class, and I did too. And so here's what I would remind you. This is a practice of nursing, a practice of medicine, a practice of whatever. You got to practice it. And you'll never be adept at doing these fundoscopic exams if you do 6 or 8 of them. You have to do a bunch of them, to be honest. And one day you're going to do one. Practice it on everybody. They come in with a sprained ankle, do a fundoscopic exam on them. And you know what the patient is going to think? You see, that's why I like to come to Amelie. She's so thorough. All right. So just do them, and one day you're going to go in and boom, you're going to see it, and you can say, oh, and the patient's go, my God, what's wrong? So it's going to come, I guess, is my point, but you got to practice. How many people have had a chance to use one of these? No, not too many people. All right. Listen, if fundoscopic exams were so easy, they wouldn't have those. They wouldn't have that. You got it? So this one is really for idiots. You just like plug in and then click, take the picture. But you know what? Don't you wish when you did a fundoscopic exam and you looked in that they had labels? Because I'm thinking the man upstairs made a mistake on this one, right? It would be so easy to tell what's what if they had labels on them. To me, that was a definite error. That was a mistake. All right, what do you need to know about fundoscopic findings? Here's what I know. I get emails by the hundreds every day, and I try to go through every single one of them. A lot of the emails that I get are from people who have just taken the exam, and they just effuse information. They're paying a lot of attention on both exams to eye things, and I want to make sure you know about eye things. So take a look. Absent red reflex, depending on the age of the patient. Older adult, you might think of a cataract. With papilledema, we see a swelling of the optic disc. You may also see absent venous pulsations. Remember, the eye is one of the only places where the veins pulsate. It's not the arteries. So that may make you think of papilledema. But again, I want you to have a good idea of some of these notable fundoscopic findings, and here they are. At some point, a patient is going to say something, or you're going to identify something when you examine them that's going to make you think, ugh, I have to get an expensive test on this patient. An expensive test means an $800 CT, a $1,200 MRI. You're going to have to get it. You will live a frustrated life if your note doesn't reflect what an insurance company is looking for. What they are looking for is one or more of these terms. Because when they see this in a note, they realize, oh, this is a criterion to give authorization for one of these expensive tests. So I want you to look at it. I want you to be familiar with it. And you will live a much less frustrated life as a brand new NP if your note reflects one of these, and then you'll be able to get authorization for your expensive test. And when I tell you an expensive test, look, I'm talking about either a CT or an MRI, and just very basic comparison to these two expensive imaging studies. Remember imaging studies? I think you'll need to know for your exam. Two of the primary differences between CTs and MRIs are these. If you want to look at a cavity, you get a CT. If you want to look specifically at soft tissue, you get an MRI. One of the reasons ERs use CTs all the time is because they are quick. You can do it rapidly. But there's a lot of radiation associated with the CT. And so, for safety purposes, we don't like more than 2 in a year. Compared to an MRI that takes a whole lot longer to get, but it gives us a really, really good look at soft tissue, a meniscus, a disc, a tumor that's embedded in soft tissue. We get an MRI, all right? So those are two comparisons that might help you. And I have something here for you, and I need to make sure you know it. You never, ever order contrast with an MRI or a CT, and it's probably with a CT, when there's a suspected what? Bleed. Exactly, right? You're never going to use contrast. So if you're going to get a CT of a brain because you work in the ER, typically you don't see contrast dye ordered there. In primary care, you have the option to order it. If there's any suspicion that there could be a bleed, you never ever use contrast. All right, so just some important issues for you. I'll let you take a look. But in primary care, we often order CTs, we order MRIs, and if they need something beyond that, pick up the phone and call radiology. Whenever there's a question, radiology will give you a good idea about what you may need to order depending on what you're looking for. All right, everybody with me? So don't be afraid. Don't hesitate to call radiology or the imaging center where you're going to send the patient. Tell them what you're looking for and let them make a suggestion because, man, if you order the wrong test, it's an expensive way to go. And then you got to get the right one. All right? So let's take a look at headaches. What's the most common headache seen in primary care? Is the migraine headache, right? They come in. These are often disabling headaches. About half of primary care visits for headaches are migraine headaches. Migraine is considered to be an episodic disorder. What does that mean? It occurs in episodes. So if you have one migraine headache, you'll have another one. How do you diagnose a migraine headache? If somebody comes in, very often they'll tell you, oh, I have migraine headaches. I think I have one right now. I want you to look at them and say, how do you know you have migraine headaches? They usually look at you and say, well, I don't know, but it's real bad. And it must be a migraine headache. So you got to ask them, who diagnosed you with migraine headaches? And if they say me, it's probably not a good answer. The way we really do diagnose someone with migraine headaches, especially migraine without aura, is you got to go with these characteristics. So look, they come to us and they are universal, international. The International Classification Headache Disorders, these are the criteria that you're supposed to ask about and document. If your patient meets these criteria, then you say they have migraine without aura. And then you treat them appropriately. But you can't just write migraine on somebody's chart as a diagnosis unless they meet these criteria. I don't expect you to memorize them. Keep them in your pocket until they're just part of your working knowledge. You don't need to memorize them for the exam. But I guess my take-home point, or your take-home point, is this one. You are about to be given a privilege that very few healthcare providers have. It is the ability to make a diagnosis. When you make a diagnosis and you put that in somebody's chart, you got to make doggone sure it's the right one. I tell people all the time, it is easier to expunge a criminal record than a bad diagnosis in a chart. So when you write something down for chronic disorder, you better make doggone sure that's really what they've got. So when you diagnose migraine without aura, they need to meet these characteristics and you need to write it down, make sure they're in your notes. Take a look at this question. What's an example of an aura secondary to a migraine headache? And this is a select all that apply question. What's an example of an aura secondary to a migraine headache? Well, listen, an aura always stimulates some sense in you. The sense of smell, the sense of taste, the sense of vision. So, number one, metallic taste. Some people will tell you they have a certain taste, they know they're going to get it. They have a smell. They have blurred vision. They have scotomas. They have something. Those are all examples of auras secondary to migraine headache. Which one is not? Not sneezing, right? So number 1, number 3, and number 4, the 3 you should circle. Those are all examples of aura. What's an example of an aura? 1, 3, and 4. Everybody with me? What about the diagnosis of with aura, migraine with aura? Well, they have to meet the other migraine criteria, and an aura has to be present, and now you know what to look for. What do we know about auras? When a patient has one, they're kind of lucky. You know why? Because within 60 minutes, they know they're going to have a headache and they can get their drugs ready. Because the earlier you can treat a migraine headache, typically, the better off your patient's outcome is. You should know common triggers for migraine headaches. And some of them are real easy to identify, like maybe you drink red wine, you have a migraine headache. You have menses, you have a migraine headache. But sometimes the trigger is something like cheese. And you're not really thinking it was pizza last night that I ate, and now I have this headache. Or, about a week ago, I went and had a po' boy with ham and cheese, and you might not get it. So triggers, if you can help your patient identify their migraine triggers, they will be very, very appreciative, especially if it is something that they can avoid, like maybe cheese.